Sorry,
Yes, ma'am, we can see your slides.
Perfect. Yeah. So today, the first initial part of the discussion is about which I'll be dealing with is about the ethics in pediatric palliative care, and what are the usual dilemma which we face, and some basic principles which we follow to come to work around this dilemma which we face in a day-to-day practice. So when we talk about ethics, what is it comes to our mind when you try to say ethics, especially in medical practice? What do we mean by ethics?
Would anyone want to unmute themselves?
Or you can put it on the chat. Doing the right thing, correct way of doing things. Absolutely.
Morality and the patient's interest.
Patient interest, moral values. I think that is like how we decide. Like I see a lot of response, like what is right, doing right, and often what is right is judged by one of the factors which decides us to makes us to see, okay, this is the right way, but based on our moral value. Many other principles are there, like which helps us to say what is right or what is wrong. Who decides? Like what is right or what is wrong is based on several factors, like our moral value, our belief system, culture, the legal dimension to it, and all of many other factors which actually helps us to shape what is right or what is wrong. I absolutely correct way of doing things and principles. Yeah, absolutely agree with many of the responses which you mentioned right now in the chat. So it's all about connected with beliefs and principles of what is right and what is wrong, like as you very rightly mentioned. And when we look at ethics in pediatrics, the first thing which comes to our mind is the capacity of decision making. We often, first thing which we will say is children cannot decide for themselves, and that is the biggest ethical dilemma. So we don't know what is right for the child, and often we rely on the caregivers to make decisions. And sometimes, most of the time, they know the best what they needed for the children. But sometimes we come across in our medical practice situations where sometimes we feel that it may not be in child's best interest, and children are made vulnerable because of the parents not being able to decide the child's best interest. So then that's the time we really face a dilemma, what is right for us. And as a professional, we are responsible to advocate and protect for the welfare of the children who are vulnerable. Children as a whole, as a population, we all know that they're the vulnerable group. When we say vulnerability, in many ways they are vulnerable, but we as a professional, we have this additional responsibility when we're dealing with children to ensure that they are supported, their vulnerability is not exploited. So this is very specific to very ethics in pediatric practice. But when you talk about pediatric palliative care, it becomes all the more difficult because we are dealing with children who are with serious illnesses, very sick and fragile. That makes it more complicated, and many times they cannot. All the more they cannot decide for themselves, and they totally rely on others. And our focus is when we talk about what treatment is right for them, when we're trying to maximize the quality of life, minimize the suffering, all these factors, when we are considering, it becomes more difficult when we are dealing with children. But one thing for all of us in everyday practice, goal of a good pediatric healthcare is promoting the best interest of the child. I think if this is something which we just remember, I think many things will be very helpful in deciding what is right best for the child when we promote the best interest of the child. I think throughout today's discussion, I think we are going to come back to this again and again. Now look at this child. As an example, I thought let's look at some of the very common things which we see in our practice. This is just name change. Mithun, a 12-year-old boy, high risk acute AML, post BMT, and now he has relapsed. Child is presented with profound fatigue, gum bleed. He's bleeding from many places, and he also seems to have bone pain because of this disease condition. Heavily treated already, he received intensive chemotherapy and undergone all the toxicities of the transplant There was a mild graft versus host disease. And finally, when they did the bone marrow, there was a relapse. But the child is repeatedly receiving blood transfusion, and the last transfusion was done a week ago. Now, this time again, because obviously he's bleeding and his platelet is low, and the medical team decided to go for more transfusion. But the child refuses any more injections. He just simply wants to go home. He said, I don't want it. And we are in a dilemma. What should be the right way forward? What do you think is best thing for him? Imagine this child is bleeding now. Of course, we know that it's a relapse, but he's still bleeding, and bleeding can lead to many more complications. And he's suffering because of bleed. There's a bone pain and a lot of fatigue. But just last week, the transfusion was given. Again, the count seems to have dropped. So, what do you think is the best way forward for him? More blood transfusion? Not to go for blood transfusion? Or is there any other way to deal with this problem? What is that comes to your mind? If you can just put down in the chat, or you can just use the unmute yourself if you want to say something. So Dr. Hafsa says, focusing on comfort care. So you don't want to, it looks like Hafsa, you decided not to go for more further transfusion. And Dr. Munima says, communication with active listening, explaining to him. I wonder what to explain to him, like more transfusion? I wonder. So yes, communication, I totally agree. But explaining to him that why this is so important to take some more transfusion is something you're wondering, Dr. Munima, looks like. Dr. Anubhav feels that anticoagulants and more communication. I wonder what the line of communication would be here. Anubhav, if you can just specify. And Dr. Munima clarifies that Dr. Muniba feels that it can be anticoagulant injections to stop bleeding. May or may not work here because it's a very this kind of situation. Many times the anticoagulant fails, and so it may not be very helpful. But yeah, still we can try. Any other response?
Procoagulants, yes.
Sorry, once again.
Yeah, procoagulants, not anticoagulants, actually. That's what you meant. I mean, xanthronexamic acid.
Okay. And also, Dr. Muniba feels maybe allay his fears as to what is it, why is he refusing treatment? Absolutely trying to find out what exactly his fears and worries are. Maybe he's just terrified. He's scared that he's seen other children dying, so he must be worried. So absolutely at this point to allay his fears. Dr. Bindu feels to respect child decision, but at the same time transfuse to avoid active bleeding. Yes, that's another stand Dr. Bindu has taken in terms of what's the best thing for this child. Any other response? Yes, to stop bleeding hemostatic agents. Yes. Again, anybody else would like to think about what in real life? I'm sure you see this kind of situation again and again when you're dealing with hematological malignancies. So, any other way of looking at it? How many of you are comfortable to decide? Do you think the blood transfusion is really helping the child? Let me put it this way. Do you think this at this stage of his trajectory, blood transfusion is helping him or not? Dr. Anupa feels no, because just a week ago we gave transfusion, and Dr. Hasina also feels not really. Muniba also feels not really. So, what if we take a stand? How comfortable are you to say, okay, let it be. Let's not give the transfusion. I know this is not a very usual thing to do. But it's just a reflection as to, can we think differently? What if we decide not to go for transfusion? I know it may create a lot of difficult dilemma in our heart, like as whether is that the right way to do. Dr. Sneha feels to stabilize acute clinical condition, and Dr. Hasina feels multiple counseling required with the parents in terms of futility. I'm very glad, Dr. Hasina, you brought this up, which I'm going to talk a little more about. Dr. Bindu says, yeah, but active bleeding child, how do we let it go. Very difficult, Dr. Bindu. I agree with you, not easy. And Dr. Tirumala feels, no, explain to the parents that transfusion only to tide over the crisis, but only a temporary solution. Yes, so it's a very temporary solution and it's not really helping. Within very, very soon, the child may, every 2 to 3 days, the count will drop. So how long? When do we say enough is enough? Anupa also feels withhold transfusion after clear communication and about the consequences. Absolutely. So yeah, it's a very classic example of ethical dilemma which we see in our practice. And so what we normally do, because in palliative care face this again and again. So what we try to do is go back to the basics of principles of ethical practice, which all of us are familiar. But once again, I want to walk you through the basic principles which we learned in our old MBBS days. The same ethical principles we try to apply here and see whether what is the best way applying these principles. The first principle is patient's autonomy. Patience, where the patient involves in decision making. It's about self. What does the patient want? That's the first principle. Let me make my own decision. Like if it is my body, I will decide what is best for me. So that is the first principle we talk about. Dr. Sunita also, I see this instead of transfusion, oral supplements as placebo and communication. It's all boils down to communication. I'm so glad all of you are mentioning that. So let's go back to this. So yes, first thing is autonomy. Now, how about practice of autonomy? When we say autonomy, like what I will decide what is best for me, my body. But in order to practice autonomy, I must have a full information and I must have the mental capacity to make decisions. So these are the two crucial elements when we talk about autonomy. When I decide, there should be full information. And so in order to practice autonomy, as a physician, we have this responsibility to provide patient full information in a language and wording that promote patient's understanding. Instead of minimal, remember the communication discussion which we had, so discussing and giving full information which the patient can take it, like not like full medical jargons, but in a simple language, so that they can then, and they have the capacity to make decision. But this is good for adults. What about autonomy in children? Because that is where we get stuck often. Adult is also difficult because we hardly respect autonomy in a regular medical practice, but it becomes more challenging when you talk about autonomy in children. In pediatric practice, decisions are often done by parents and family without any doubt. Very rarely the pediatric patient's input is considered. If it's often secondary, it's not the primary, it's often decided by the parents. And it becomes more challenging because very often when a child is not in a mental capacity to make decisions, especially we see when they're cognitively impaired, the language or the motor capacity. So that is the norm in autonomy in children. But all the important bodies the world over, they say that autonomy is the right of the children, even the children, that they have the right to make decisions supported by their parents based on the information given by the healthcare workers. Now, that is very important. What information? The information should be given to the child in a way that they understand, and then they must be informed and they're empowered to participate in decision making. That is a consensus. Even though we don't practice autonomy, even in adult, less in children, but even in children, people talk about autonomy. So the children must be given information. So what about informed consent? So this whole discussion comes, then it boils down to informed consent. We know that a definition of informed consent, it is especially in context of pediatrics, it's a permission for the children's participation in research, diagnostic procedures, treatment and care. And it's usually parental permission. But how about autonomy in this context? Yes, and parents make right decisions on behalf of child who lacks decision making. However, we should ensure that they are in the best interest. In medical practice, we all take informed consent. We take signature when you do any procedures or research. We take parental consent. But as a medical professionals, we should ensure that parental decisions are right. But there's something also called assent, which we discussed already. Assent is child's willingness or preference to participate in a therapy, procedure, or research. The child also has the right to give assent. A mere failure of the child not objecting does not mean that the child has given an assent. In order to get the assent appropriately from the child, again, like I said earlier, we must be able to make aware of the condition, test, or treatment being given in a developmentally appropriate way. Again, all of you mentioned in your chat about communication. It all boils down to communication, but in context of a child, age-appropriate communication to explain what is being planned, and then engaging the child to express his view based on based on his mental and the child's age and mental age, allowing the child to express what he thinks, and that should be considered in assent. And this is something universally accepted, and it's a standard practice being followed everywhere. When you look at ICMR guideline in terms of research, they say very clearly 8-year-old child should be told exactly what he or she is going to undergo, and 15-year-old assent should be similar to informed consent process. So we talk about autonomy, very poorly practiced, I again and again am saying, even in adult, but in children also, they have the right to practice autonomy, provided they get the information and they're given the choice to make decision. The second principle is doing good. So how much good is the blood transfusion is going to do to Mithun? Like we all agreed, limited role, but how much actual benefit is giving? Just a week back, he received the last transfusion. So is it really going to be beneficial? There's something called life-sustaining medical treatment, a therapy which can extend survival to some extent, or the consensus exists towards that. And many things are considered as life-sustaining medical treatment, like assisted ventilation, artificial nutrition and hydration, renal replacement therapy, vasoactive infusion, which we all do in a medical practice towards end of life. And we keep on doing it without thinking much. But these are all the considered life-sustaining medical treatment. And transfusion, oxygen, antibiotics, these are all, they're put under, it comes under the category of life-sustaining medical treatment. And when we decide to forego life-sustaining medical treatment, either withholding or withdrawing, the debate is it right or not? And that brings and it often creates the medical, ethical, and legal dilemma. And in this case, transfusion is an example of foregoing life-sustaining medical treatment. So is that right? So often we are in a dilemma, legally, ethically, and medically. We are not discussing legal here. We can bring up in the discussion, but here we're just focusing on medical and ethical part of it. And same thing applies here. The consensus the world over is that applying the interest of best interest also applies here. That means favoring interventions that are likely to provide greater benefit than burden for the child. We have to debate, is it going to provide more benefit? Are we causing more harm? We all know that blood transfusion is also causing a lot of harm to the child. What harm can have blood transfusion? What harm can it produce, blood transfusion? Can you think of the harmful effects of blood transfusion? In this context, repeated blood transfusion, already child has undergone too many toxic treatment in his limited life. And then again, you're suggesting blood transfusion. Can it be harmful at this point of time in any way to the child? Yes, allo immunization, absolutely. Anything else? Repeated painful cannulation. Blood transfusion, you can't just give by small vein. You have to get a proper vein. As it is, these children, they're finding vein is so difficult unless they have some central line already in place. Finding cannulation is a big problem. And that requires hospitalization. And very rightly pointed out by Dr. Bindu, financial burden, cardiac overload, very fragile child, very sick child. Too much of fluid or blood transfusion can actually cause more harm. The child will become more breathless, pulmonary edema, and cardiac overload. So, and so much of burden and pain and suffering to the child and the family, and a lot of infection which may introduce, which may or may not be relevant at this stage, but it still need to be considered, and the cost involved. And each time the when you think about blood transfusion, shifting the child from home to the hospital, is it really aligning with our comfort care, the goals of care as comfort care? No, it may not. Just the blood transfusion can actually reduce the comfort of the child. So all of these things we have to think. So when we're making this decision, we have to see how much it's like intervention is it more beneficial than the burden? And the standard says that discourage or initiation or continuation of intervention that are likely to lead to greater burden than benefit. So universally, this is a standard recommendation that it should be we can forego life-sustaining medical treatment, looking at the best interest of the child. And if it is not causing much benefit, burden is much more than the benefit, then we are ethically all right to forego this kind of treatment. So we talked about autonomy. We spoke about doing good, how much it's really doing good, but definitely we should not harm. We should not cause more harm. Yes, all children are entitled to effective medical treatment that is likely to prevent serious harm, suffering, or death. That is also important. And we should always consider risk and benefit of medical treatment, ensure that treatment do not cause more harm than good. I'm just quoting this from the very standard recommendations brought out by American Academy of Pediatrics and many other similar bodies. So they very strongly, they talk about doing no harm to the child. One of you mentioned the futility of treatment, which I'm so glad you brought it up. What do you mean by futility of treatment? When do you say a treatment is futile? When do you think a treatment is futile? Is something called futility of treatment. So what does it mean? Generally, we talk about futility where we all give treatment expecting some benefit, isn't it? We'll expect some benefit the child should get. We call it treatment futile when we are unable to achieve a benefit above certain minimal threshold. Even a little benefit we cannot achieve above the minimal threshold, that treatment is considered as futile. Can you think of a classic example where we consider the treatment is futile? Can you think of a situation where you really feel that this is really, you come across this? Yes, I see Dr. Hafsa, no benefit or more harm than benefit will not improve child's condition. Yes, but above certain minimal threshold, minimum benefit we should get. Can you think of a situation where you think it's a chemotherapy in a resistant disease? Absolutely. Giving again more chemotherapy in a resistant disease, changing antibiotics in end-of-life cases. These are all, like example, as case blood transfusion in relapse situation. These are all the futile treatment. But somehow we get into this trap of continuing to, just for the sake of doing something, we continue to give treatment which are futile actually. Futility is such a strong word, but we do it in every day in our practice and without thinking. And like I said, it fails to achieve the minimum benefit. So, but benefit, who decides that beneficial or not? It is a very subjective thing, benefit. Physician definition of benefit may be different from what the patient may feel. You may look at the parameters and say, wow, saturation is improving. But the child may not perceive the benefit because child is feeling so much pain and suffering. He'll say, it's not, please take me home. It's not helpful. Sometimes when we are in ethical dilemma, we are not sure what is happening. The recommendation is better to go by child's or family's perception of benefit. When we are not sure, ask the patient or the family. And they will tell you, no, doctor, please, it's not helping me. And that's the way people, the recommendation is. So futility is something often we come across in the practice. And like I said, does the treatment have physical side effects? And the harm, it's not just a physical harm. We have to look at, as you mentioned in your chat, the harm is physical, emotional, social, and financial harm. All of this can cause harm. It's all the dimensions of suffering. If you're adding more suffering by your intervention, then it's not really worth going for it. And then comes the very important part of the justice. the balancing the need of the individual with the society and the family. Fair utilization of resources. You order one transfusion, already the family of Mithun has spent all their money, all their resources to undergo bone marrow transplant and all the chemotherapy, and they have this one house left, and they have few more children, and now you say blood, one more blood transfusion, it's going to cost money. They may decide to put even that house on mortgage to go for that one transfusion. We may not think all that when in a regular practice, but imagine what's going on in the background with the family, and they sell that house or put the house on mortgage to come for that one blood transfusion. Absolutely. And so that is not a fair utilization of resources. Imagine the future is gone because of this one decision. When you talk about, oh, my hospital gives free blood transfusion, but somebody's resource we are using. I rather use that blood product for more useful situation. Maybe there's another child waiting to receive the same blood who may be benefited. Some child who's undergoing surgery or some treatment, maybe that is more beneficial. And and when you talk about public hospital or government pays for it, but someone is paying for it. So fair utilization of resources. That is another thing which often makes us to decide whether to go for it or not. So finally, when you look at Mithun, when I ask this question, is the blood transfusion is going to be helpful to Mithun or not? There is no clear right or wrong answer. Very thin line between this side and that side. That is the reason we came up so many responses we came up with. And one of you mentioned, like, how can we stop transfusion? It's such a difficult decision. It is a difficult decision. We never know what is right or what is right for us. Sometimes when we are in such dilemma, it's useful to look at all the four dimensions, all the four principles, and then take a stand. Patient's autonomy, is it going to be getting any perceived benefit? Are we causing more harm? And fair utilization of resources, and that will help you sometimes to make a better judgment of what is best for this child, whether to go for blood transfusion or not to go for blood transfusion. The reason I discuss this case is because in pediatric palliative care, we face this ethical dilemma, especially in end-of-life care situation, again and again. Every day we face this. I'll share some examples. Like first thing is which came up again in the beginning itself, the child's ability to participate in decision-making and consent for treatment. How much information should we give to the child? Often the family is saying, don't tell the child. And the child is kept in the dark. Most of the time, they don't know what is happening. But they do get information from various other sources and in social media. And they get so terrified. But there's no way they can talk about it and causing more harm to the child. Family focused decision making. Very often the family do this. I'll try everything possible for my child. And sometimes that part of it cause more harm to the child than doing good. And when we don't know where to stop, when to stop, and many a times heavily influenced by cultural and moralistic preferences. Because of lot of this fear about ethics, law, and our own poor understanding about medications to be used in children, the ethical dilemma of undertreated pain and symptoms. Some other examples of ethical dilemma which we see in pediatrics is making advanced care planning, which Dr. Veronica is going to talk more about, when to decide to forego treatment, when to suppose a child is on ventilation, when to withdraw ventilation or not to go for on ventilation. These are the classic examples where we face ethical dilemma. Often the request by the family, put IV fluids, child is not eating anything in end-of-life care situation. Total parental nutrition and end-of-life care situation. Or sometimes we use what we call the palliative sedation for very intractable symptoms in end-of-life care situation. These are all very ethical dilemma where we do, oh my God, what to do? We discuss with the team and we use the interdisciplinary discussion, involve all the disciplines, and sometimes we are still not sure. We use the hospital ethics committee and then we take our decision. But remember, the only message I want to give here is that there is no right or wrong answer. The child's best interest should be the core, which should be there when you're thinking about what is the best for the child. Aim for a balanced compromise, all the four components. Still, if you're not sure, ask yourself this question: what if it were me? What is that I would have wanted for myself? I stop here. and take questions if any. Otherwise, we'll end off with a discussion also. We can take more questions.
There are few questions in the chat now.
Okay. Okay, let me go back to there were the examples. What question, Vigla, if you can read out? Okay, what if the kid refuses treatment, doctor offer treatment, even if the parents want it? Again, it's the whole decisions can be taken. The child understands based on his mental age, developmental age, what is the child wants, what does the family wants, and what is the best we think is right for the child. And we call it shared decision making. We should all come together, have a consensus, and take the decision. But we should not but what is happening is very rarely we come across very difficult situation, and we remember that as the ultimate example, and we say, oh, it is so difficult. What I want to say is that at least in regular clinical practice, involve the child, understand what he wants, and take a decision. Very rarely we'll come across where we don't have a consensus, where the child is not aligning with family or you, and all are in three different directions. Then we don't know what to do. Then I would have somebody else come and call in your team, to some seniors who are more experienced in dealing with that situation, and then take a decision. Because many times I come across situation, I find it difficult, then I'll look around, I'll take other disciplines help to make a decision. But important thing is that the only message I want to give here is that the child should also be heard. Often we don't do that, we don't even talk to them. The child should be heard, and there's somewhere their willingness is also equally important in deciding what treatment and what investigation they need to best for the child. We'll have more examples because we have more next time we're going to have discussions around compassionate extubation, palliative sedation, all this situation. Again and again, we're going to come back about this shared decision making, where the child and the family is at the core, and all the disciplines coming together. So so we'll have more examples when we come back to all these cardinal principles of medical ethics, which we'll be applying. Okay, we'll come back to more discussions, but Veronique, maybe you can take it from here.
Yes, thank you very much. Thank you, Gayatri. And yes, we can, if other questions come to your mind, we will have ample time after my presentation to go back also to the ethical issues. Just making sure that you can see my slides in a...
Yes, we can see, but please make it a slideshow.
Yes. Yeah, trying to.
Yeah, thank you.
Showing, yeah, great. So after understanding the ethical issues that are present at the end of life, what I would like to discuss with you is how the objectives of the second part is to see how to improve our communication with families, which is especially important at the end of life. And then this concept, very important concept of advanced care planning, which Dr. Gayatri mentioned, and also transition of care, transition from active treatment with curative intent to palliative treatment, and especially when we are getting closer to the end of life. What is the place, the best place for the end of life, and what management plan do we make? And of course, always keeping in mind the need for addressing physical needs, emotional needs, spiritual needs, and all the social issues that come along with in the whole family dynamics. And then bereavement care, which will be spoken about in next session, but I only mention it here because it's part of our the way we look at end-of-life care. So as you all know very well, being a pediatric oncologist, We have about 50,000 new cancers every year, and many of them in India present with advanced stage or have refractory disease or relapse. We also face in PHO also, I think one of the cases we often reach end of life is severe aplastic anemia. And the survival of pediatric cancer is very poor in low and middle income countries, including India. Many do not reach or they reach very late. So even though there is improvement in the access to care, we can see we are very much behind. And the Union government has fixed now a goal of reaching 60% survival of cancer by 2030. So when I read that, it says going from 50 to 60. I don't think we are even at 50 when we look at all the children who are not really starting even treatment. So palliative care services for children are very, very limited in the country. So it is the responsibility of everyone who sees a child with cancer to improve, to ensure that we can provide good end-of-life care for those patients. And you are in the front line because you are the ones who who treat those children. So I'll take the case of Amit, name changed, a 12-year-old boy who was in the PICU when we were called palliative care. Reference was given for a case of metastatic angiosarcoma. So the primary tumor was on the chest, on the skin, with multiple lung mets, and the child had been shifted from the ward to the ICU because of respiratory distress. So he was already on non-invasive ventilation. He had been actually symptomatic for 2 years and presented to the hospital very late. And the child was saying, I don't want to stay in this ICU, I want to go to ward. He was breathless, he had cough, he had pain, moderate pain. And so we sat down with the parents, as we usually do, pediatric oncologists, palliative care clinicians, that would include a counselor and either a nurse or a doctor, in this case a doctor, and with the ICU doctors. And then we discussed the goals of care. And parents were very clear that they knew that the disease was quite advanced. It's a very difficult disease to treat. They didn't want intubation and they didn't want CPR. It was just ventilation and chest compression we do not want. So what we decided to do is to start treating breathlessness and cough and pain, all three being actually responding to morphine at a low dose of morphine. The child improved. He could be shifted to oxygen after 2 days. It could be shifted to the ward. Oxygen was tapered off. And throughout, after multiple conversations, both with the child and the parents, they wanted to try curative intent. So, okay, we are very, that decision was taken. 2 chemo cycles were given with the idea we will check if there is response. And on CT scan, there was no response. So then again, goals of care discussion. And at that time, parents understood that there would be futility of continuing high-dose chemotherapy. They opted for home care in the village, was sent on oral metronomic chemotherapy and on morphine. By that time, we had increased the morphine, especially for pain. And then we followed up on the phone because the village was quite far, and ensured that there was morphine availability for him in the nearest cancer center nearest to that village. And then the child was cycling, very good quality of life. He was studying online, and he died peacefully 6 months later. So I don't know, when we see that at some point, the questions that could come to us is, this child is so sick on an IV and we don't want to intubate, where to provide maybe we are reaching end of life care at that point. So, and then the child was clear that he didn't want to be in ICU. Thank God he improved. But in many cases, we may have end of life care in the ICU and decide to provide comfort care there. Or we may be able to provide it in a separate room, like in the private ward in the hospital. And at some point, then the decision is taken for home care when we understand that we are getting closer to the end of life. So what is the end of life exactly? When is it end of life? And it's a very difficult answer. It could stretch up to maybe 6 months, 1 year, when we understand that we are looking at a terminal illness. A terminal illness may take time. But right now, I think we are more talking about end of life when the child is going to be, especially in the case of cancer, advanced progressive cancer, it is much easier to predict than in other life-limiting illnesses. How to predict when the child is approaching the end of life, and it is not a reversible clinical deterioration. We may have a lot of like those dips in the health, and then the child has a febrile neutropenia, and then gets in and out of ICU because he improves. But when also in terms of predicting or prognostication of time, it's always very helpful to look at the speed at which the child's condition is deteriorating. If the child is worsening from weeks to months, we can safely say that life expectancy may be estimated to be from weeks to months. When the condition is worsening from days to weeks, we have probably the child has days to weeks to live. Hours to days, then the same hours to days of life expectancy. So it's always important not to give a number because most of the time we will be wrong. If you say the child has 2 months to live, and then see our child was alive at home for 6 months, and then parents will be waiting, what is happening? So in palliative care, we always remain in that estimation because really, truly, we do not know. And communication with families is very important at many points of time. We see here when Amit is in the ICU, we see it when he's back in the ward, and then again, goals of care are being discussed. And then when there is no response. So providing full complete information about the illness and about the prognosis, starting early, not when we are reaching only the stage of no curative option, and regularly we revisit it again and again. And especially when there is no hope for, meaning we know that there is no hope for cure, but we do not want to remove all hope because there is always hope for control of the disease. Somehow we give OMCT, we try to control the progression of the disease. Hope for symptom relief, hope for the best possible quality of life. And I think both Amit and his parents and the whole team was very happy to know that he was able to cycle and enjoy good quality of life. But that communication has to be clear and at the same time compassionate. You have had 2 sessions on communication, so but that idea, I am sorry to give you such bad news. I wish it were otherwise. But the illness cannot be cured and the child will die of this progressive disease. It's important to be clear. I worry and I wonder what can be done with the time that is left. addressing emotions at all stages and spiritual distress when it is expressed. Emotional distress, spiritual distress. So in how to make that transition from curative to palliative, and that those family meetings, as much as possible, including both the PHO team and the palliative care team at a time of relapse or refractory disease, is very useful. Maybe in some centers have the habit of saying, okay, now we speak to the family from the onco side, and we send the child to the palliative OPD, and we say, this is for best supportive care. Now you take over, hand over. And that's not, it's much better to do that handing over together so that they see that we are working together. If we have been introduced earlier, that's much easier, early integration of palliative care. But if not, it's like we keep hand-holding both from the PHO side and from the palliative care side. Providing information about illness and prognosis early and regularly. So much, for example, if we are in touch with the family when the child is at home, and we give guidance regarding medications, and we have all those updates, we always keep in touch. We keep updating the PHO team. This is what's happening. Good news or sometimes bad news. Sorry, I went back. No, this is done. So now I'm going to spend more time on the advanced care planning, which is a set of discussions between the families and the healthcare providers in order to establish the preferences for care and the goals of care based on the current health of the child, and also anticipating what is going to happen in the future. So these advanced care planning is the gold standard to ensure that the preferences of the family and of the child regarding end of life are made very clear and are honored. So, and as I mentioned earlier, it is an ongoing process. It's going to keep on evolving. And there will be several triggers to do more intense advanced care planning, to revisit it when curative treatment is exhausted, at the time of relapse, when there are new symptoms that are difficult to manage, and when really the burden of treatment exceeds the benefits and it becomes futile. So there are various steps that I will be mentioning. The first one is defining the goals of care, which may shift from, in this case, curative intent to maximizing the quality of life. So maximizing comfort and trying to find meaning to what's happening to the child. So we always avoid that thing of saying nothing can be done, nothing else can be done for your child. No, we try to look at the positive things of what can we do, and preparing the parents for this transition. There is a very important role of the pediatric or the medical oncologists who are treating the child in the presence of the clinician, so that transition can be happening smoothly. And we reach a shared understanding from the clinical team that provides information to the family about illness, prognosis, what are the various treatment alternatives, and including palliative options. We can go for aggressive treatment, which has very little probably a chance of benefiting the child. What are all the alternatives? We do not make the decision for the family of what we think is the most in the interest of the child. The family has to take that call, provided the information we give them is clear enough. And then the family shares, we invite them to share their values, their hopes, their fears. We need to ensure that the family understands properly and all the information we are giving them. They may not be ready, and we may call it a day and call for a further meeting later in the evening or the next day, having more family members who can support them. Then talking about medical interventions and treatment limits, as we saw Dr. Gayatri told us in the previous talk. So the how much of cancer-directed therapies, life-sustaining treatments, the resuscitation status, not just DNAR do not attempt resuscitation, but actually positive thing of allowing natural death. It is the same, but the way of talking about it is different. The child is going to die of the illness in any case. What do we do with monitoring antibiotics, blood products? And then talking about the location of end of life and the location of death. So eliciting the family's preferences. Choices are usually home, hospital, and hospice. Home, both in the Western context and in our Indian context, is most often the family preference. But hospital is actually the most practical one when they say, how are we going to manage with symptoms? And when symptoms become unmanageable at home, they may need to come back to the hospital because we may not have the luxury of having a hospice. But actually, hospice care would be the most appropriate in those cases, both for respite care, providing respite to the caretakers, to the family, and also for end-of-life care. It is rarely available in India. We have few hospices throughout the countries that can accept also children, not only adults, and children-specific hospices are very few. Now we have that in Hyderabad, and Dr. Gayatri can tell us more about that. In Delhi, and kids can provide that, but we need more hospices. So maybe you will be providing end-of-life care in the hospital. And so when we choose home care, we really try before any discharge to the home, which is often a village in another state, maybe liaising with whatever resources are available. What is the nearest oncology center or palliative care center, or being in touch with the local physician who may or may not be a pediatrician, and sharing with them the plan of care, which we will speak about later on. And also planning for sudden changes of mind from the family, sudden logistic needs. So we already plan with the family, okay, we are sending you home with home care facility whenever it is possible, or telephonic support, and also with a plan if there is a need for rapid hospital readmission, if they cannot manage at home. So the plan also of transfusion will be made if initially, especially in hematological malignancies, leukemias, it's difficult to go home with a plan of not transfusing from the start. And we see that problem is not so much there in solid tumors, but in ALL, AML, we see that parents are used to regular transfusions, and they will take their time going to a local hospital. So we plan that for maybe PRBCs or for platelet transfusions. And slowly we follow up with them. They will decide, now today is the last one. We don't want to come again to the hospital. But we are there for them and support them in whatever decisions they make. Then management of symptoms, anticipatory management has to be also planned, because there will be progressive distress, especially pain. Now, we give priority to pain because it is the most common symptom in children with cancer, and it is the most feared symptom. Anxiety, dyspnea, nausea. So what to do? Whom to call? for us to titrate the medications or to start. No, the child goes on paracetamol, but with morphine tablets with them, and then call us when the pain is not controlled, and we will tell you what to do. And so emergency medications for acute terminal events are also ready in an emergency kit with immediate use medications, morphine, midazolam, spray, and other medications that would be maybe have not been started at the time of discharge, but will be needed in the future. And remember that many symptoms in cancer, in children with cancer, are actually not resolved despite our best effort. We see weakness, that is the most difficult symptom to treat. Pain, most of the cases we are able to respond to manage the pain. No, in black you have the symptoms that respond to treatment, and then the symptoms that are not resolved in white. So the ones on which we can really work: constipation, vomiting, nausea. Nausea is a very important symptom which we do not pay attention to, because we say the child is not vomiting, but it is a very debilitating symptom. I won't go into any detail of symptom management because that has been spoken about last week, if I'm not wrong. And then psychological and spiritual support, as well as planning legacy. Legacy is how the child would like to be remembered, how the parents would like to remember the child, how the children as young as 5, 6 years old would be worried about who is going to have my toys, distributing their belongings, because children have a very acute sensitivity and understanding of what is happening to them, understanding that they are actually not getting better and slowly that they are going to die. And then asking the parents and the family about spiritual needs and cultural needs. Now, preparing them also, if we think that end of life is coming very fast, especially in hematological malignancies, we do not have much time when we send a child home or when we decide for palliative intent. Then what are the rituals, the traditions, the beliefs that they have, so that they can plan that. Especially when we are talking about hospital, it would be more difficult for them. They don't have that freedom of maybe much of the family support, the community support. So these are important to plan also, and support that we can provide for siblings. If a child is going to die in the hospital, siblings, we invite the parents to bring the siblings to the hospital. And no matter what are the rules of the hospital, and the management always can relax the rules for a child that is dying. So, I mean, I give the example of this 11-year-old boy dying after bone marrow transplant for JMML, and dying of very severe CMV pneumonitis, and on NIV in the ICU. And then his sister flew all the way from Northeast to be able to see him in the ICU. She was 9 years old, and she was able to give him to drink and spend time. And these are things that we need to, we would not know it if we don't ask the family. And documenting the care plan, all these advanced care planning, to ensure that everyone in all the teams, whether it is PHO, PPC, emergency, casualty, if we think the child is going to come back, or we have whatever, emergency and services, anybody who will have the helpline and get a call should know the family's wishes, and keeping in mind that those wishes may change and we need to be flexible because parents panic. We cannot tell them, you have made the decision of not giving platelets. Your child is having severe epistaxis, so you come to casualty, but no, we will not give platelets. No. Those, as we said, the advanced care plan is revisited and discussed again and again. A lot of communication is needed many times. And providing with emergency contacts also, the family with all the emergency contacts of people who are familiar with the care plan and can guide whenever there is a crisis. So there is a very useful tool that is useful when we are talking about adolescence. And these are evidence-based guides that enable the patient to document their wishes for end-of-life care and building legacy. So you can go and check this on the internet. It's a PDF format. This voicing my choices. How does the child want to be treated? And it makes it very easy to discuss all those aspects with the child, the teenager who starts thinking and saying, do I really want to go on a ventilator? No, all those aspects and more, what do I want for myself? How do I want my, I feel that my dignity will be when my health starts deteriorating. How do I want to be remembered? And talking about the place, whatever helps relieve the suffering of the child and of the parents is the most important. Sometimes we know home care is the best care, but many times we have parents who come back to the hospital, or the child who insistently asks to come back to the hospital, and may after 2 days see that actually I'm not getting any transfusion, I am not getting any IV antibiotics. All the care that I am being provided here is the same as I could get at home. And actually, I want to go back home. Sometimes we have to do trial to agree to what the child decides. And when we talk about home care or even hospital end-of-life care, we empower the family members to provide that end-of-life care, to take an active part, and including the siblings. How much can they do for the child who is nearing the end of life? And we need to do more to be able to ease the suffering of children who choose to die at home, because many die without relief of their symptoms. And what we want is to ensure that the child dies without pain and in peace. And that is really the success of our end-of-life care. So it is not easy at home, because in urban centers that are in the cities, then we may have home care teams that are there, but adult home care teams that have limited pediatric experience. And that's when the PPC or the pediatric oncologist has to help the home care team to provide that support. And in rural areas, there is very limited home care access. So local physicians need support when they feel unqualified or unwilling to manage a child at home. But it's very important that they can go on a home visit and update on the phone the clinician, maybe the PHO or the PPC, who can say what next can be done to relieve that dyspnea or no. And then also there is cultural pressure. If the family says that it's a male child, try all possible treatment, then we go into those ethical dilemmas. There are models, as I mentioned, in Telangana, we have district palliative care at every district hospitals that Dr. Gayatri managed to set up. And there are home care teams starting from those districts going to all the villages. In Kerala, it is mostly a nurse-led model with a lot of involvement of the community and volunteers. In Mumbai, for example, we have Titi Home Care, which is the only pediatric palliative care besides Tata Memorial Hospital for their patients, and it is mostly nurse-led. So we do have home care, but where there is no palliative home care, then local doctor, healthcare providers, you've had some examples have been given by Dr. Mansi of how we manage to mention with the we manage with the ASHA worker, local A&M, and then we can provide proper symptom management, support the families who decide to stay at home. So these are the ideas of the advanced care planning. And communication, when death is near, is important because, as I mentioned, children, even young children, are very perceptive. They know something serious is happening. They see their parents very sad, and then they are aware that even parents, when they are hoping for cure, know that things are not going as they were hoping for. So we help them to navigate through these difficult decisions and ensuring comfort. We reassure them that what we want is a comfort, both that's what you want and what we want. And always seeing what are their worries, their fears. And what next can we expect? When new symptoms come, then what next can happen? So that's a very dynamic process. How come children understand this? I think this may have been spoken about in a psychosocial session. No? But so very young children just react to the environment, emotional environment. Mommy cries, I cry. Children who are 3 to 5 have that magical thinking. Maybe I'll die because of my fault. Maybe I'll die like my soldier, and I'll come back. I mean, I'll come and live again. Older children, 6 to 10. I mean, these ages are very flexible. No, it depends on the maturity of the child. But they understand that death is reversible, and it can be due to a disease, and it can be due to my disease. And then teenagers understand that death is irreversible, and everybody dies, and they understand their own mortality, but they feel that it will not happen to me. No, invulnerability. I can, but ultimately, every child has their own interpretation of death and dying. So often, but using storybooks that talk maybe about the death of a pet, or about trees, no, the leaves die, fall and die. These are opportunities for the child to start speaking about their own fear of death. And why is this important? There was a study done in pediatric oncology, a retrospective study of asking parents who had lost their child to cancer, did you talk about death with your child at any time? And only 1/3 said, yes, I have, while 2/3 had not spoken to their child. Among those who had spoken, both the groups were asked, do you regret having spoken or not spoken to your child? And none of the parents who spoke to their child regretted speaking about dying, whereas 1/3 of the children, or a little bit less, sorry, 1/4, 27% regretted not having spoken. But among those who had not spoken, about half could sense that the child was aware of dying, even when they had not, whether they regretted or not. Half of the parents were feeling that the child was aware of it, but did not speak about it. And we were afraid of speaking. We didn't want to speak. So that we need to identify when the child has that feeling, to give an opportunity, to give an outlet for the child to speak about their fear. What will happen? Who will take care of my parents? Often they are not. They may be afraid of what is going to happen next. But and I'm almost going to finish, because then you can ask questions that will be more useful. And post that transition, we continue the support once the child has passed with bereavement. That families have a special bond with the PHO and with the team that has provided end-of-life care. And it's very important. They may take a lot of time to want to come back, maybe to the hospital. It's a very, very difficult decision. Sometimes they have to come very fast because they have carried an oxygen concentrator, which they are going to bring back. But they cannot go to the oncology department, or they cannot enter the hospital. We have to go to the gate. But they may come to the palliative care department. And whatever it is, that connection will always be there. And it will take the time it needs. But that bereavement care we'll speak about next week. And also ensuring the well-being of the staff. No? I think it's important to check on each other, both the oncologists, like the role of the palliative care counselors is also to support the younger and not younger pediatric oncologists who have also a little bit of their heart that has gone when the child has died. So debriefing, having memorial moments, writing a card maybe to the family when we will go for the bereavement visit if they are not staying too far, and may carry something on behalf of the PHO team. So that bereavement care is important, and parents may also we have support groups that are being organized in various centers that have pediatric palliative care. So holistic palliative care that includes end-of-life care is feasible, and that transition to end-of-life care doesn't mean that we end care, but it's a shift towards specific hopes of cure, towards hope of care, and ensuring that we do more good than harm, and we stop the interventions that procure more burden rather than benefit. And then in that way, all children with advanced refractory relapse cancer can have optimal holistic care, not till the end. And so I did not give you chance for questions during the presentation. So now we have 15 minutes for questions, for comments. Please, I think, unmute yourself because you have a lot of experience in that field. You may have children you want to talk about or scenarios. So I see here, when we have some child responding to our interventions, Arti is asking, it's easier for us and for the family, of course. How do you manage when it is a bone tumor with multiple mets? We know we have a long time before end of life can happen. Symptoms are not easily controlled. And this typical is neuroblastoma, high-risk neuroblastoma. We may have osteosarcoma, Ewing sarcoma, I understand, but even bone mets is going to take time. There will be new mets that happen in new places of the body. And again, it is quite, we need to both manage pain, manage decreased oral intake, which really anorexia is going to set in and we will have cachexia. We've not spoken about this symptom, but helping parents to understand that their focus should not be on nutrition, because maybe it's going to feed the tumor rather than we are not talking about growth of the child at this point of time, but comfort. When the child body is not able to take more, then we should not force feed, for example. So parents know that we are talking about months, survival months to years. No, I've seen metastatic neuroblastoma, maybe living for 1 year, 2 years. and we are there hand holding when every new symptom happens or increases. We are there with them and we try to manage the symptoms, and always with a lot of psychosocial support for the family. So what are the service? I don't know if I answered the question, or you want to unmute yourself, Aarti?
Hi,
And
ma'am.
Dr.
Thank you for the answer. Hello,
Yes,
can you hear me, ma'am? Yeah.
yes,
So
Aarti.
my main question was about the bone tumors, because somehow we see even with fentanyl infusion, morphine, and tramadol, round the clock management, they are the cohort of people who really suffer. Like neuroblastoma, depending on the site, if it's brain, and then they sort of become vegetative, but they don't really understand the suffering. But when it comes to brain bone tumors, and especially the adolescents, it becomes very difficult to answer the child as well as the parents, because it's like whatever you do, it's, at least my experience has always been, a suboptimal response, irrespective of when it comes to metastatic bone tumors. So that is one thing. Because counseling also becomes difficult, and keeping in the hospital is very it's difficult because of the finances mainly. Because
Yes.
you're occupying a bed, we're already short of beds, and then we're also not providing symptom relief. So the family starts questioning what exactly we are doing by staying in the hospital. So we've advised hospice care a couple of times, but they're not mentally prepared to go as well. So I would really want to know how exactly you deal with these scenarios. The others, I think, somehow are still okay. Neuroblastoma or any other tumor which is going to be slow growing, or depending local site, they're going to be symptomatic. But the bone pain is something which I feel has, at least with my experience, has been the worst.
Very bad. So we will definitely add non-steroid anti-inflammatory to morphine. We need to make the child pain-free before thinking about any discharge. So fentanyl, tramadol, you've had a class, and Dr. Gayatri has given the class, I think, given a class on pain. I don't know who has taken it. We will choose one strong opioid, and as much as possible morphine, oral morphine, and with adjuvants. There can be a component of neuropathic pain also in bone pain. So gabapentin may also help. NSAIDs, sometimes a short course of steroid also, 5 days course of steroid. But I think transition, maybe Dr. Gayatri can speak more easily of transition to hospice care when it is integrated. The same team, hospital, home, and hospice makes it very easy. I think we need to introduce the people who do the hospice care to the family for that smooth transition. If you have a hospice close to your hospital, that team needs to be involved. So either somebody from your hospital goes with them, it can be a social worker, goes with them to introduce to the hospice. No, Gayatri, that continuity of the healthcare professional is very important for the transition.
May I add to what
Yes.
Veronica said?
Yes, Gayatri.
You said. Aarti, first I'll respond to your question about this. It's a very difficult combination. I totally agree with you. Bone pain with the the bone malignancy like osteosarcoma and adolescent age group. This combination is one of the most difficult. Our team, they burn out dealing with such patients. So it's not a very easy, I totally agree with you, a difficult, very intractable pain situation. And as Veronique said, always we think about again, we go back to the assessment part as to what is the source of pain. And bone pain, it's a syndrome by itself. Bone pain, and it's an entity by itself. But often there's infiltration of nerves, as Veronique mentioned. Periosteum is infiltrated. Often there's underlying fracture and a muscle involved. So it's very combination of, physiological point of view. If you see combination of many reasons why it becomes so difficult. So often, like Veronique mentioned, we'll add opioids. I would rather start with oral opioids, need not have continuous fentanyl infusion, because how long will you give? because I don't want the child to be hooked onto infusion forever. So we'll always plan strategically, titrate oral opioids, like Veronique said, morphine. For me, because it's a complex pain condition, because I have methadone, I use a lot of methadone in this situation because methadone has an added advantage in this kind of complex pain condition. It has an additional action on other receptors other than opioids, like NMDA receptors. So, from pathological point of view, it's very helpful. So, methadone NSAID combination is something which we have seen works very beneficial, along with some non-pharmacological interventions like splinting and muscle relaxants. But like Aarti, you said, the combination, like I said, adolescent with lot of psychosocial thing in the background with this pain makes it more complex. So addressing the psychosocial component of child's distress is something which we spend a lot of time doing it, addressing to their needs because which is so complicated. Yeah, so this is the thing stand we take, trying to help those such children, even though it's very difficult. I want to respond to Dr. Tirumala's question about hospice. So we have a pediatric hospice. So the indication for hospice, like Dr. Veronique mentioned, hospice is somewhere between home and the hospital. Hospital is where we have all this typical hospital, any hospital. Home, home. Hospice is it's a facility where it's like home. You have a nice surrounding where the family is allowed to be with the child, and you get the food prepared as per the child's need, more cleaner, more nursing staff support. At the same time, you get the entire medical support which you typically get in a hospital. When I say medical support, means palliative medical support. You have all opioids available and a highly skilled doctor and the medical staff giving the best of medical care in a home-like environment. So when you talk about admission to hospice, the indications are either very difficult, intractable symptoms when the child does not want to go back to the hospital, like your Dr. Aarti's situation, bone pain. I'll manage when the child say, I don't want to go back to the hospital. I'll rather admit that child in the hospice because better supported, where we have more staff, and it's much more friendly than hospital. Hospital is never a friendly atmosphere. So intractable symptoms. Another indication for hospice admission is end of life care, especially again, the child does not want to go back to the hospital and very difficult to manage in the home. Very intractable symptoms like a lot of dyspnea, very difficult pain, a lot of delirium. So sometimes we admit for difficult, intractable end of life care situation. Another important indication for hospice admission is respite care. The parents are exhausted looking after the child and they need a break, and some event is happening in the family, or sometimes we have a very famous family in our hospice admission. They come almost every month, they come back for admission. Why? The mother is handling two cerebral palsy children in the same household. So she gets so tired. Sometimes she says, I want a break. So she'll bring both the children and put in the hospice, and the hospice team takes over the care of the child, and then the mother just relaxes. So respite care. So these are three indications: intractable symptoms, end of life care, which can be managed in the home, and respite. These are the three indications for hospice admission. There are more questions I see.
Yeah, there are two questions about what to do when the parents come back to the hospital with symptoms and they want, again, interventions to happen, maybe ICU or... So here it's a matter of communication, really. Again, sitting down and saying, what would be the benefit and what would be the burden of the ICU, ventilation, no? Hospital stay, that is more difficult because it's very much case to case, no, Shrishti? I think that to understanding, avoiding hospital stay, sometimes we could try to create some hospice-like environment in the hospital. So in my case, in a public hospital, the onco department doesn't want, the PHO doesn't want to have a child that is going to die or that is on palliative intent alongside the other children, because everybody gets demoralized. So we would admit in some other pediatric wards, or if possible in a single room. But we can provide that family atmosphere also, allow all the relatives to come. In government hospitals, places like that, we have to make this happen. If there is no way for the family to go back home because they are scared, because they're not managing the symptoms. and we don't have hospice care, hospice facility. Yes, Gayatri?
I may add to a couple of points. Like first thing, like very clearly Veronique said, it's all about boils down to communication. So when the parents say best of care, so again we go back few steps back again to the communication. We say, what do you mean by best of care? Like sometimes for them the concept of best of care is my child should not suffer. So I don't make assumptions. That's the basic rule of communication. When somebody says I want to give best to my child, so I'll take a step back, sit down, tell me what do you mean by best of care. Best of I would want to do everything best for my child, in what context. So then we go back to how much they know and know about the diagnosis, prognosis, and then build upon that. And then we use the same concept of I wish, worry, wonder, like best and worst case scenario. We use this some of these techniques to make them understand. Yes, even I wish that a child gets better. But what if your child is not getting better? Have you thought about a situation? What if your child will not get better? So it all is about communication. And very often a child and the family, they rush back to the hospital. First of all, we need to understand why are they rushing back to the hospital. Often when there's a crisis, they rush back to the hospital. So Dr. Veronique mentioned about the crisis plan. So if you have a crisis plan in place, anticipating this child will bleed or this child will have in sudden increase in pain, and when you anticipate or sudden increase in breathlessness, we have a plan in place. So this rush to the hospital chances are much less. They may still come back to the hospital, but they will not seek desperate. They won't come to the emergency seeking or do something like they know they will seek for palliative care. Can I meet the palliative care doctor? I know that they explained to me, but my child is very breathless. I want to meet the palliative care doctor. So they are much more prepared, and that reduces the chances of escalation of care to ICU, ventilation, those kind of things. If they're better prepared, and once the problem is that once you escalate the treatment, it's very difficult to bring it down. De-escalation is the most challenging part. So our whole effort is make sure that give the we don't give the chance to escalation and anticipate crisis and manage the crisis. And that's something very helpful in the situation. Smriti, we give blood transfusion in the hospice. Like I said, we have everything. It's a very registered, like a nursing home kind of facility where we have a pharmacy, we have qualified doctors, so we give blood transfusion in the hospice. So for that reason, they need not go to the hospital. So those are the kind of things but it all depends on different setting of the hospice. In our hospice, we have taken that stand that we'll take care of these things. We do pleural tapping, blood transfusion, and ascites tapping, and acute pain management. All those things we do in our hospice. Some hospices may not accept that. So it depends on which hospice, what is the hospice policy. I think we are coming to the...
I'll take Ravali's question also. I think this is we see lots of children who are quite well preserved. Now, you see older children who have good quality of life, they go about their daily activities. So what do? We encourage them having those daily activities. Talking about daycare transfusions, for example, if you have a teenager with severe headache and anemia, the best treatment of your headache will be a blood transfusion. So we will, in those cases, morphine is not going to help. We need to transfuse, for example. So the benefit here will be to give. I mean, I'm just saying this because it just came to my mind when you talk about daycare transfusions. So I'm not sure if I understand your question, but the child knows they are going to die, and they can go about their daily activities. We always try to talk about what improves the quality of life of the child, the interests of the child, their activities. The child knows he's going to die, and often we may be thinking, but what? I remember a girl, 11 years old, with Ewing sarcoma of the leg. The leg was already enormous. She already could not walk, and she was always coming to the OPD with a child, with a sibling, the small sibling, and playful and whatever. And I was worried, asking my senior counselor, can you just check again with her whether she understands her condition, her situation? She was always so cheerful. And then she spoke to her and told me she knows, but she wants to take care of her brother, and she's cheerful. We are treating the pain, and but she knows she doesn't want to be told all the time. So every child is different. But we will definitely focus on the visit to the grandparents, going to the village when they wanted to go for 2 weeks to the village, then they came back to the city. All these are very important part of the life, and the child is living, is alive till the child dies. So it's not a child that is dying. It's a child that wants to live to the full, and we try our best to make it happen.
Thank you. I think that was a very interesting, fruitful discussion we had today. Long day for most of you. So yeah, I think two more very interesting. I think you should not miss next two sessions which are coming up, especially about the palliative sedation and compassionate extubation. And we'll be looking forward to seeing you again. Thank you.
Is there a session on bereavement also, the last one, or it has already happened?
Bereavement and yeah, the two sessions, total sessions, and we'll be, as like I said in the beginning, we'll be just briefly telling you about some few new development which has happened in terms of we are thinking about nurse building capacity building in your team. So let's see, we need your input also in that. So we'll brief you in the next session. So Nandini has some announcement. I think Nandini and Vinila.
Yes, ma'am. Thank you, ma'am. I think really I would like to thank both the speakers for taking out time and answering all the questions and for this wonderful session. And I request all the doctors to please kindly share a post test, which is posted in the chat box, and also please kindly give your feedback, which will help us improve the sessions. And I think this week, two more, as my speakers mentioned, there are 2 more sessions left. The next session will take place on 13th March, same time, 7 p.m. So as mentioned earlier, requesting all the doctors to kindly please join the session by 7:15 p.m. Thank you so much, and thank you one and all.
Thank you. Good night, everyone.